Welcome to Rumor versus Truth, your trusted source for facts, where we dissect the evidence behind risky rumors and reveal clinical truths. Today, we're exploring heated claims around hormone replacement therapy for menopause.
So, Don, when I got the memo, we were talking about hormone replacement therapy today. I thought, didn't we just do a testosterone episode?
Yeah. We sure did, Steve. But that episode led to several listeners, they're asking us to talk about another major hormone, which is estrogen.
Yeah. Oh, so a spinoff. Okay. I like that idea.
Mm. Okay, so before I hog all the credit here, hello, everyone. I'm Don, the pharmacist.
And I'm Steve, the pharmacist.
And you could probably tell by now in this episode, we're going to take a pause so we can learn about menopause and look at claims about hormone replacement therapy, focusing mostly on estrogen.
Yeah, timely topic for sure. And speaking of time, it's always a good time to get CE. This podcast offers continuing education credit for pharmacists, pharmacy technicians, prescribers, and nurses.
All right, so just log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses.
And for the purposes of disclosure today, none of the speakers have anything to disclose.
That's right. So we've got a lot of questions about hormone replacement therapy, commonly abbreviated HRT or HT for hormone therapy lately, especially with FDA's recent change in boxed warnings around these products for menopause.
Yep, and there's lots of talk out there on the internet, TV, social media, you name it. And it's important that we have the facts to really help our patients on this.
All right, and speaking of facts, stick around. We'll also answer our listeners' question about GLP-1 side effects from our last episode.
And, I don't think we do this topic justice on our own, Don. So for this episode, we've enlisted the help of one of our editors again, Sara Klockars, PharmD, BCPS, to help us tackle these claims. And she's done a lot of research on this topic. So welcome, Sara.
Yes, welcome, Sara. And before we kind of put your feet to the fire here and cover the facts about hormone replacement therapy, can you give us a rundown about menopause and where estrogen actually plays a role?
Sure. Thanks for having me. Menopause is a normal part of aging in all women. Essentially, it's where menstrual cycles stop permanently for at least 12 consecutive months. And most women can expect this to occur between age 45 and 55. And this occurs because of that declining hormone production by the ovaries. And that it also includes a drastic decrease in estrogen, which can have many effects on the body, not just stopping periods.
Yeah, so many effects. Can you tell us about those?
Sure. So many women experience symptoms for several years before menopause, and that perimenopause transition phase sometimes persists for years, and symptoms can persist for years after as well into menopause. Patients can experience vasomotor symptoms during this time, and those are those hot flashes or night sweats. And it can also lead to genitourinary symptoms such as vaginal dryness, burning, itching, and urinary symptoms such as frequency and urgency. Patients can also have migraines, mood changes such as irritability, depression. You hear about brain fog and loss of
Mm,
concentration.
mm,
And really, the list goes on and on.
Right. And since low estrogen is a cause of these symptoms, it does make sense that giving estrogen replacement is one way to treat these patients, right?
Yeah, putting those pieces together in terms of
Mm,
menopause, and that's a
Right.
really good review. So, going into claim number one here, knowing estrogen's role in menopause symptoms, it leads to the question or this claim that all patients with low estrogen levels should use HRT. What is your take on this, Sarah?
Well, generally, lab tests are not required for the diagnosis of menopause. So we don't know if someone necessarily has low estrogen levels, but the diagnosis is made clinically based on the patient's age, menstrual changes, and irregularity. And then those symptoms like the hot flashes are
Mm.
what I personally try to think of as power surges.
Okay, so power surges. So how common are these?
Well, up to 80% of menopausal patients report bothersome vasomotor symptoms, and other patients may not have problems at all. So, but for the majority, menopause is a real challenge when it impacts your sleep, your personal relationships, your emotional well being. And that's when we would consider treatment rather than relying on lab tests alone.
Yeah, and thinking about lab tests here, I did look up recommendations from the Menopause Society for this episode, and they note that, quote, salivary and urine hormone testing to determine dosing are unreliable and not recommended. Serum hormone testing is rarely needed. So, interesting point there.
Exactly, Steve. So those hormone concentrations fluctuate greatly during that perimenopause phase, especially with those irregular cycles where you may be going months without a cycle. And they don't really stabilize until up to 6 years after that
Mm.
final menstrual period. The American College of Obstetricians and Gynecologists, or ACOG, also support the recommendation that hormone testing isn't recommended during perimenopause or before starting hormone therapy for most patients, since levels aren't likely to offer useful info. However, there are certain cases that levels are helpful, but they're not always needed.
Yeah, good caveat there. So, when it comes to this claim that all patients with low estrogen levels should use HRT, the verdict is rumor. So the decision to start HRT really comes down to whether patients feel they have bothersome menopause symptoms affecting their life rather than relying on estrogen levels.
Yeah. Not to mention weighing benefits and risks of therapy.
True.
Some patients may have contraindications for use, right? I agree, levels don't appear to correlate very well with symptoms here. So it's difficult to use them for treatment decisions. And if you think about all the added costs with healthcare, labs do add up to it, right?
Yeah, good thoughts are
Mm,
there. And
mm,
if a patient qualifies for therapy, we have a helpful FAQ chart managing vasomotor menopause symptoms that gives a helpful rundown on various options, including estrogens and non hormonal therapies.
yeah, good call out. And remember, just like many things in medicine, we need to treat the patient, not the numbers, right?
Nice.
And speaking of numbers, let's move on to our claim number 2 here. And it is bioidentical estrogens are more effective than other estrogens. So, Sarah, glad you're here again. Spells out for us. What makes something a bioidentical estrogen?
Yes, so bioidentical estrogens are estrogens with the identical chemical structure as those produced by the ovaries. So, as an example, estradiol is a naturally occurring hormone the body makes, meaning it's bioidentical. Another example of ethinyl estradiol, that is not bioidentical since we don't
Mm,
make this chemical structure or hormone in our bodies.
right. That's a good common distinction that we kind of see in pharmacy, right? And I've heard some healthcare professionals differentiate between formulations, referring to compounded formulations
Mm.
as bioidentical while calling the commercial available FDA approved formulations body identical. Very there's a nuance there, right? But
Yeah.
uh, it sounds like they mean the same thing, and perhaps it comes down to marketing.
Right. So there are both commercially available and compounded bioidentical hormones. Another estrogen we'll chat about more is conjugated equine estrogens. And these are extracted from pregnant mare's urine and are not considered bioidentical to human hormones since they're from horses, obviously.
Yeah, and Premarin is the brand name of that kind of product example, and it's named since it's extracted from pregnant, so PRE, pregnant, mare, MAR, urine. The Premarin, that all makes sense. So clever naming there. So then are bioidentical versions more effective?
Good question. Based on the evidence, all forms of systemic estrogen appear to help with those vasomotor symptoms when compared to placebo. We can't say necessarily that bioidentical estrogens are more effective since we don't have many head to head trials. Some would say that would be putting the cart before the horse.
Horsing around with some puns now. Okay.
It's also important to note that compounded bioidentical hormones have less data, and there are so many different formulations and combinations out there, and they're not evaluated by the FDA, just to note that.
Okay, good. Thank you for kind of bringing that in there. So let's go ahead and go back to that claim, which is bioidentical estrogens are more effective than other estrogens. And the verdict is rumor. So it looks like we might be naysayers on this one. We don't really have enough evidence to say one way or another. It's important to think about the route and tailoring the choice to the patient. For example, I have had some patients prefer a compounded product to get a customized dosage.
Yeah, good point. And a good reminder that patients should use a US licensed pharmacy, ideally accredited in compounding, to really help ensure safety and quality with this.
Yeah, good point. And while there's so many options out there, we can use our menopausal hormone therapies chart to help you compare product, dosage forms, strengths, and more. We have a column in there to identify which hormones are bioidentical.
Yeah, that's super handy. And take a look at the show notes or description since we've linked directly to that resource in Pharmacist Letter, Pharmacy Technician's Letter, and Prescriber
Hmm.
Insights, as well as our Managing Vasomotor Menopause Symptoms chart we talked about earlier.
Yeah, and if you aren't a subscriber, don't miss out on these resources. Sign up today to stay ahead with trusted and topical insights and tools.
Good segue, Don. Topical indeed, because it's our next claim that topical estrogen is safer than oral options. Again, Sarah, over to you.
Well, this is a bit nuanced and complex due to some limited, robust safety data. But just to take a step back and clarify, topical estrogens can include transdermal patches or sprays. For example, those products you put on your skin, and also vaginal products such as the creams, rings, or tablets.
Good to point that out. And, since drug absorption and levels in the body aren't necessarily the same with all of these, right?
Right. So, yeah, we rely on transdermal options to provide systemic levels. And that's where there's enough to get absorbed into the bloodstream to treat those vasomotor symptoms as an alternative to oral therapies. When it comes to vaginal products, there are different amounts absorbed depending on the product. So, we have a low dose vaginal option that only
Mhm.
helps with those local symptoms, those genitourinary symptoms. And there's a higher dose estradiol acetate ring, femring, and that provides systemic levels to treat those vasomotor and vaginal symptoms. Um, just one little tidbit is keep the vaginal ring straight with this phrase. A ring, so thinking fem ring, is bigger than a string. Think S string. So fem ring provides that higher dose for systemic effects, and S string is that lower dose for local effects.
Right. I mean, we do love our mnemonics here, right?
That's for
Yep.
sure.
So, what is the evidence around safety then?
Yeah, so let's start with the orals. Most of the well designed hormone therapy studies in menopause are with oral conjugated equine estrogens, that Premarin, with or without medroxyprogesterone acetate, another synthetic progestin. So these options may increase risk of blood clots and stroke, especially for patients who are older than 60 or more than 10 or 20 years from menopause onset when starting it. So we also have observational studies that suggest a lower clot risk with estradiol compared to oral conjugated equine estrogens.
Okay. And based on that, where might this thought then come from that transdermal products are safer?
Yeah, so when it comes to transdermal preps, which are still systemic, so they're being absorbed like those orals, but they are associated with a lower clot risk than oral estrogens, since the transdermal preps avoid that absorption in the stomach and the metabolism in the liver. So they're not getting broken down in the liver, and they have less of an impact on the clotting factors. And then this is thought to also apply to femring, which has likely a more favorable safety profile than oral estrogen as well.
Hmm.
I do want to note we do even have a safer option. So we have those low dose vaginal estrogen products that have minimal absorption. So we'd anticipate fewer risks as well. We have some observational data that suggests these options are not linked to blood clots and they can be used at any age and even in patients with a higher risk of blood clots.
Yeah, that data seems reassuring then.
Yes, yes, it does. And even though we're relying mostly on observational data, these meds have been around for quite some time. But overall, robust evidence of various estrogen products different estrogen doses, different formulations, and even different progesterone options in there. Um, and in other younger populations, that evidence is just really missing from this whole picture. So that makes it hard to draw some good conclusions for most other safety outcomes, such as, cardiovascular events or fractures.
Yeah, I can see where that's tricky to really sort it out. So when it comes to this claim that topical estrogen is safer than oral options, the verdict is true with conditions. Based on that, it's a good practice to look at personal and familial risk of things like cardiovascular disease, stroke, and blood clots before a patient starts hormone therapy. And let's not forget smoking, since that really impacts risks too.
Right. Glad you mentioned the smoking. And transdermal options may have a lower clot risk. It's important to think about those non-hormonal options, including paroxetine, fezolinetant, or
Yeah.
elinzanetant. Said those right. For patients with a history of heart attack, stroke, or blood clots, or at a high risk of thrombotic disease.
Yeah. And that reminds me of our great article about elinzanetant in the January issue, a pharmacist letter, pharmacy technician's letter, and prescriber insights. And we also have more answers to questions about transdermal and vaginal estrogens in our managing genitourinary menopausal symptoms chart.
Oh, that reminds me, Steve. Looking back at our audience questions, I remember we got some talking about this really. I think cut the estriol patches in half to lower the dose.
Yeah, we kind of
What do you
talked
say about
about
that? Yeah.
we talked about the dosage and what that kind of effect can have. And really when it comes to patches, a lot of this can depend on the product. Many estrogen patch products are adhesive matrix
Mm.
patches where that drug is kind of spread out throughout the adhesive layer, and those might be okay to cut since the drug is evenly dispersed in there. But it's always important to check each product individually,
Right.
carefully to make sure.
Yep. Open those huge package inserts and take a look, or you can look at them online and kind of figure that out too. So to help you out, another clinical resource, we have our characteristics of transdermal patches chart that reviews various estrogen patches and administration tips.
Yeah, very helpful chart there. And before we get into our last claim here,
This episode is helping you cut through the noise. Here's something to make your professional life easier.
yeah, already a subscriber, don't forget to claim CE credit for this episode.
And not subscribed yet or thinking about upgrading, access more trusted clinical insights and save 10% with our exclusive listener promo code RVT1026 at checkout.
Yeah, and details and links are in the show notes, so don't miss out.
Okay, so for our last claim here, we're saving the controversial one for last. For you, Sarah, it's been talked about for a long time and has recently been in the news. So the claim is hormonal replacement therapy causes breast cancer. Over to you, Sarah.
Well, I can piggyback off the prior discussion in terms of evidence using that conjugated equine estrogens with medroxyprogesterone acetate study. The Women's Health Initiative went on for about 5 years. In women, it was stopped early. Um, it was the average age, mean age of around 63 years, but it was stopped early because it was linked to one more breast cancer case per 1,000 patients per year. So that's what sparked a lot of the controversy with breast cancer.
Yeah, and when you said, 63 years, to me, that's quite an older patient population. Since the average age of menopause, we were kind of talking about is around 50, like 51, 52 years. And that risk also sounds kind of low.
Yeah, great points there. Exactly, Steve. And to put the risk in perspective, it's slightly less than having 2 glasses of wine daily, and it's similar to the cancer risk from obesity or a sedentary lifestyle. The other thing with that study, there's another side to this. The use of estrogen alone, so those patients who'd had a prior hysterectomy, was actually associated with a reduced breast cancer risk.
Hmm.
There's also other evidence to suggest estrogen alone has little to no increase in risk of breast cancer. So, there's definitely a more complex interplay here between estrogens and progestogens than initially thought. And the latest is, the progestogens might actually be the driver of the increased breast cancer risk. So there might be a lower risk of breast cancer in patients taking micronized progestin compared to those taking the synthetic progestin, such as medroxyprogesterone acetate.
Right. It's a good kind of points to bring up. And that I could bring in that FDA's announcement that happened in November 2025 that it removed the box warnings about breast cancer risk from hormone replacement therapy products. But that kind of leaves that subset of population who has a
Mhm.
history of breast cancer, right? So since some of these cancers rely on supply estrogen, what's the thoughts there?
Yeah, so there's definitely more of a risk there, although evidence is limited and conflicting. But to be on the safe side, systemic hormone therapy is generally not advised for women who have a history of breast cancer, especially if they're hormone receptor
Mm.
positive.
Yeah.
Um, but I do think it's safer than we initially thought when that 2003 Women's Health Initiative study stopped
Mm.
early. And it may be used in select severe cases after, weighing risks and benefits and having that discussion with the provider. Um, the bottom line is, as we kind of alluded to earlier, that low dose vaginal estrogen is a better option for these patients if needed.
Great wrap up. Thank you. So let's go ahead and head back to that claim, which is hormone replacement therapy causes breast cancer. And the verdict is evidence is mixed.
Yeah, I'd agree with that, Don. Breast cancer risk is low and may depend on which hormones are being used or at what age we're talking about, and hence the recent boxed warning changes for these products. But extra care is needed in patients with a past history of breast cancer or other estrogen dependent cancers. And typically, systemic therapy is avoided here, while vaginal estrogens may be an alternative.
Yep. And also remember there are non-hormonal therapies such as oxybutynin and gabapentin that may help patients. We cover these in our Managing Vasomotor Menopause Symptoms chart to help sort out options when estrogens may not actually be ideal.
Yes, a very handy chart there.
Mhm.
And thank you so much, Sarah, for helping us clear the air once again on a timely topic. You've helped us cover acne, GLP-1 side effects, and now menopause in our episodes. Quite the spread, and we could not do it without you. So thank you.
Happy to help. Thanks for having me. It's been fun covering this hot topic with you guys.
All right, and as Sarah is leaving, when it comes to this bottom line truth for today's episode, menopause symptoms can be bothersome for many women, and healthcare professionals
Mhm.
can help patients sort through treatment options, benefits, and risks that we talked about.
Right. And it's important to listen to patients' concerns and offer options, especially when menopause is generally undertreated.
Yeah, I didn't realize how undertreated it is. So
Mhm.
don't let treating menopause make you sweat too. We have several tools for pharmacist letter and prescriber insight subscribers to help guide decision making.
Sure. And speaking of decision making, I decided it's time for the Rumor versus Truth mailbag. And we have an audience question from last episode about GLP-1 agonist side effects that came through our send a text link in the podcast show notes. You might recall our last episode was all about GLP-1 agonist side effects. And that one listener asked, do GLP-1s cause chronic cough?
Yeah, that's a good question because looking into this, Don, I did find a recent observational study back in November 2025 that looked at over 400,000 patients taking GLP-1 agonists
Mhm.
such as semaglutide to see if they had a higher risk of this side effect.
Mhm.
And they found that patients did have a higher risk of chronic cough compared to patients who were using other diabetes medications, things like glipizide or canagliflozin. This was after controlling for existing gastroesophageal reflux disease, or what we know as GERD,
Mhm.
that we also know can cause coughing. But keep in mind that this was only an observational study. It was not a randomized controlled trial that can say that GLP-1s can cause chronic cough. So keep that in mind.
Right. So, you know, kind of want to know any thoughts on why that could actually happen?
Yeah, this really is not intuitive. I kind of struggled at first to think this through. But there is a thought that this is due to GLP-1 agonists causing GERD, since
Mhm.
we know that GLP-1 agonists slow down stomach emptying, causing
Mhm.
food to maybe potentially back up into the esophagus and cause that irritation and coughing symptoms and reflux symptoms we associate with GERD. But
Mhm.
another theory is that GLP-1 agonists may stimulate the vagus nerve, a special nerve in our body that has an important pathway that impacts our breathing. But this is all very theoretical at this point. That study was not designed to figure out a cause, but it is something worth watching out for. So if a patient maybe has this issue, consider whether symptoms are possible GERD or potentially whether it's worth switching to a different med if it really does become more bothersome. And we'll have to wait for more data, to be honest. But really
Right.
interesting question.
Right. Yeah. Yeah. So thank you for addressing the why there. At least in the theoretical sense, it kind of gives the nerds in us kind of the background.
A
things
reason.
Yeah. Yeah. So
Yep.
you retain it longer, right? That's what I keep telling myself. My daughter asked me why 10 different times when she has to do something. So I won't hold my breath on, the reasons why. But if you'd like to, if you'd like to have your questions about this episode answered next month, send us a message.
Yeah, we also use your suggestions to plan our episodes, just like this one. You guys suggested we should do menopause. So email us at rumorversus.truth@trchealthcare.com or send us a text right from the podcast show notes.
Before you go, claim CE credit and access evidence-based resources from Pharmacist Letter, Pharmacy Technicians Letter, and Prescriber Insights.
And if you're not yet a subscriber or want to upgrade, you can save 10% with our exclusive listener code RVT1026 at checkout. It's an easy link in the show notes.
Are you a subscriber? Tap the credit link in the show notes or search your CE organizer for this episode.
And join us next time where we'll get to the root of the claims around hair loss.
So thank you for joining us on Rumor versus Truth, your trusted source for facts, where we dissect the evidence behind risky rumors and reveal clinical truths. See you next time.